Okay, right. Okay, so before we begin, we just like to let everyone know that this is being recorded and it could be for at a later date. Okay? All yours. Oh, go for it.
For the slide.
Your introduction.
This is our healthcare committee meeting. I'm Jennifer Dublin, the chair. We also have the vice chair on Zoom. And I would like to introduce you to Dr. David Little from South Brooklyn. He could speak about diabetes as an illness. And so we also have the, what's the name, Mary? Hannah. We also have Hannah, who's gonna speak about diabetes also from the medical physician point of, the clinical point of.
Pharmacist, yeah.
Before we begin, we just also want to let you know that we do not have quorum, but we're only gonna have an informational meeting. Only because certain people didn't show up, but people are on Zoom and we want to give them the benefit of the doubt of the meeting tonight. Okay, so take it away.
Is there a way that I can have the?
Oh, I can move it up and down for you if you want to.
It's every bullet is a click though.
Okay,
so-
that's fine. We can do this.
Yeah, I was gonna say.
Sure. Yes. Perfect. You got it. Okay,
Great.
Yeah. Yep. Okay.
So-
All yours. Yes. All yours.
Nice. All right. So good evening, everybody. Thank you so much for the introduction. So my name is David Little. Or sorry, I should look at the owl.
Look at the owl.
Look at the owl. Right. My name is David Little. I'm the Chief of Ambulatory Care at South Brooklyn Hospital. I'm also a primary care doctor, and I more directly oversee our adult primary care department, our geriatrics department, and the large majority of our diabetes services at South Brooklyn. So, the talk where this is aimed more at just making sure that, give you all some understanding of, how do we design our diabetes services at South Brooklyn? How do we make sure that we're meeting the needs of the patients? How do we do our best to make sure we're meeting the needs of the community? So this should be very informal. Feel free to stop me at any time. The goal is to talk for about 20 minutes, 30 minutes, and then we'll leave time for questions. Okay, great. Okay, so first, just looking big picture, what are our goals as a hospital and as a system at South Brooklyn? So we really want to be offering comprehensive care for all patients with diabetes within the four walls of the hospital. We don't want to have to be referring people out. We want people to really have kind of one-stop care for diabetes and really get everything they need within our hospital. So part of getting there is just making sure that we have like amazing and highly trained staff, which we'll get into much more detail in the coming slides. And another really key element of this is not just offer the services and have the staff to deliver them, but also having a really robust way of us internally monitoring how are we doing. And ultimately, if nothing else, if you take home nothing else from all of the information I'm going to spit out at you, our goal is really to meet the patients where they're at, figure out what do they need, tailor our services to what the patients really need. And I'm going to show you in the coming slides that this is more than just general talk. So drilling down a little bit to what do diabetes patients generally need from us. So one of the key things, really is that a lot of it comes down to the staff, right? They need staff that are caring, that are knowledgeable, that are really kind of geared towards partnering with them. And this is kind of a growing team, including doctors. You can see doctors, nurse practitioners, physician assistants, clinical pharmacists, which we will talk much more about, the nurses and the dietitians, among others. So we need to have the staff, we need to have a way for patients to get to our facility and get to access the staff. So besides doing normal daytime hours, one of the things that I think is really important we do that we have early morning access starting at 7 in the morning. And then we have clinics that run till 6 or 7 in the evening for patients that work because most of our patients are working age. And then in addition to that, we have Saturday clinics for the patients that can't, that where the morning or the evening still doesn't help us give them a chance to get into us. So, and then, I'm sure many of you have my chart. If you're on any Epic systems, this is one of also the key ways that patients can access us. And it's an area that we're always trying to figure out how to better utilize this and better connect with patients on the my chart. And then is everybody familiar with the A1C testing here? I know. Yeah. So,
I don't. Okay. All right. Let's see.
Here, take the.
No, no, you're on. Can you guys hear us? Yes or no? Thumbs up or not? Yeah, they can hear you. They can hear you. No, no, they don't see it there. Oh, okay. Just talk a little louder too.
About- Yeah.
Okay.
Which is the mic in the owl or the mic in the laptop?
I think it might be on the laptop.
Oh, that's why. Okay.
Okay.
So I'm looking at the owl.
That's okay. Just what on top.
Got it. Owl's looking at me in the microphone. Okay.
Yeah, that's it.
So one quick piece of background information. So the core test that we use to see how somebody's blood sugar and their diabetes is doing overall is something called an A1C test. It's a very simple and straightforward blood test, and it looks at the last 3 months or so of blood sugars, and it's really by far the best test we have to see. I should say it's the best test we have now. We actually have newer ways of monitoring blood sugar that are potentially better, but as far as the standard testing we use, the A1C is really our best way of understanding how diabetes is doing. How is the volume okay now?
Yes,
All right. We'll take no complaints. So, all right. And then, patients, among other things, they need medications. And then, as I was hinting at, some of the newer ways of monitoring blood sugars are continuous glucose monitors, which you've probably seen commercials for the Freestyle Libre and the Dexcom. G7 is still their model. So, so there's the old model of delivering diabetes care, which was really that the doctor kind of does everything. The patient comes see the doctor, and the doctor does everything, right? Or at least tries to. And which would include like both medications, but diet, exercise, counseling, all that. That model doesn't work. Doctor, we were talking a little bit about this before. Doctors, they don't always have time. And one of the and their ability to communicate with patients can be a little bit variable. Some of them are very good, but as we were talking about earlier, there's not always a lot of training and communication with physicians. So they almost always know their stuff, but the communication part sometimes needs improvement. So we really use this newer model where the PCP or the doctor is really the quarterback to delivering the diabetes care, but it's really the team that is built, around them or with them that really helps deliver the care patients need. So one of the key parts of our team that has really moved the needle with a lot of patients in getting their diabetes controlled, and this is not just in South Brooklyn, but you go across our whole system, the whole city, really everywhere, is using CDTM clinical pharmacists as our diabetes experts. So just Hannah's going to talk a little bit about herself, but I'll give her a little intro. So CDTM clinical pharmacists. So again, they do 4 years of pharmacy school, but then they also do 1 or 2 years of additional training, which is quite similar to how doctors train. But again, their training is much more focused on just certain diseases like asthma, diabetes, hypertension, high blood pressure, blood thinners. There's a couple more that I always forget, but their training is much more focused. But they really, and so they can work with patients on lifestyle, but they also function very much like doctors, so they can prescribe medications and order testing such as those A1Cs. And actually, I didn't put this on here, but one of the key things pharmacists, because they also have some experience working in pharmacies, they know the little details about how insurances work and when the insurance denies a medicine, how do you work around that to get the patients what they need? And they're often the only team members that are really good at that. Um, so yeah, I think, one of the other things that they are really good at and is kind of core to their training is to work with patients to figure out, if the patients aren't getting what they need and, there are barriers to them being as healthy as they can be, really drilling down on like what are those barriers? So for medications, for example, like if somebody's not taking their medications, is it an insurance issue? Is it a forgetfulness issue? Is it, concerns about side effects? Is it just, they want to take their medicines, but they don't use a pill box, so they forget if they've taken it or not. So Hannah and clinical pharmacists in general really, part of their core training and being is really drilling down on what patients really need as far as controlling their diabetes. And another thing they do that's different from the doctors, I'm sure I'm preaching to the choir that when you're lucky enough to get in to see your doctor, if they need to see you again, it's probably not happening anytime soon, and that you're waiting, months, if not longer. Where the clinical pharmacists, we design their workflows so that they get a lot of time when they meet patients initially, but then they have very frequent follow-ups, often with telehealth and telephone. So, like for example, if they prescribe a new medicine, instead of just crossing their fingers and hope everything goes well, they follow up with the patient a week or two later, make sure that they understand how to use it still, that there were no insurance issues or anything else getting in the way. So I don't know. Do you want to? What else do you want to add to that?
That was a very like comprehensive of what I would do day to day. But I just want to add, like, we've all been to doctor visits where like you sit down and you have like one, two, three, four like list of things that you want to cover, but there's just not enough time. And especially in, complex patients when you get into all of these different issues with their health that you want to address, but like I just talk about diabetes for 20 minutes versus Dr. Little has to address all of their health complications in 20 minutes. So it just gives me time to sit down with the patient and really go over what their specific needs are to tailor, the things that we talked about, the barriers and the specific patient specific requirements to help them really succeed and take control of their health. So
Yeah,
I think that's a good overview.
that's awesome. Do you want to talk about what we're gonna? There was a specific patient because I know we mentioned the continuous glucose monitors, the freestyle. You were telling me about a patient earlier.
Um, I was thinking about a patient that I started a continuous glucose monitor for. So they're just like little sensors that sit on your arm and continuously tell you what your blood sugar is. And we've had really good success with patients actually being able to visualize what their sugar readings are. So he initially came to
Yeah.
see me because the help that he was getting with his doctor and dietitian just wasn't quite enough to get his blood sugar under control. So after he was able to see on his phone, like, oh, like when I eat certain foods, it's spiking my sugar this much, and the speed that I'm eating at really affects how my blood sugar spike versus if I walk after I eat, it really helps to bring down my sugar. So him actually getting to visualize those different changes and effects really helped him to take ownership of his diet and exercise and how those things were ultimately bringing his blood sugar and A1C down.
Yeah.
So is it kind of like a patch? I've heard it's like a patch, right?
Yeah, it's like a little patch that it's maybe like a quarter sits on your arm. It's got like a little plastic filament. It's not like anything.
There are no
It's not a
needles.
needle.
Yeah.
Yeah, it sits right under your skin, and depending on what kind of model it is, it can give you a blood sugar reading like every few minutes. So it can connect to a device that the manufacturer makes, or all of them have apps on your phone that go with it.
Yeah, I'm just asking for my mother because she has type 2 diabetes. So every morning she pokes her finger
Yeah.
and she tests her blood. and one of the doctors told her that it would be easier to have a badge,
Mhm.
but is the badge covered by Medicare?
It honestly depends on her medication regimen. We've come across most plans cover once a patient is dependent on insulin. But before we get to that point, coverage has been difficult. There are also other over-the-counter options that I can talk to you about after. If you're interested, they started making basically the same products, but you can just purchase it without a prescription. It does get a little pricey, but I do really believe the continuous glucose monitors improves like patients' quality of life because pricking yourself isn't fun. Yeah.
Yeah. Yeah. And, another part about that, thank you so much. Another part about the glucose monitors is that especially if somebody is older, or they have difficulty with reading, just getting the device onto their arm and set up correctly with the app installed, so that they're actually able to use it correctly. Like that just takes time. And like this is where that team model really comes in because the physicians, can you maybe you all have doctors who have this kind of time, but like, you probably have not had the experience where your physician is spending 20 minutes with you troubleshooting how to use your phone in this new device, where somebody like Hannah, the clinical pharmacist, we really make sure that she's set up to have that time to be able to get these kind of devices working with the patients. So. All right, I'm going to keep moving just for time. So another core member of our team that I wanted to highlight are diabetes nurses, which we have several of at South Brooklyn. And where were we? This was, I think, Barbara was talking about this before. So, nurses, just as part of we've got nurse practitioner too. So, part of the training from, I don't know if it's day one, but early on in the beginning is really making sure, from day one, learning a patient-centered and kind of patient education approach to care in general. And when it comes to diabetes, I mean, this just really pays off in spades for the patients because so much of what patients need is often just a really a good partner, somebody who comes from a place of understanding and really and wants to work with them and not just tell them what they need to do, but really learn what they need. So that's what I just said a second ago. So we have one full-time nurse who's what we call our chronic disease nurse, and that is her full-time job is to work with patients with diabetes who are, perhaps not as interested in medications or maybe don't need medications, but really want somebody who's going to be there kind of, we call like a lifestyle coach. And again, help figure out what diet changes they need to make, what exercise, would be helpful for them. Um, how to reduce stress, things like that. So, and then we have one primary nurse for this, and we also have about 10 other nurses in the practice who don't quite have the time to go into that level of detail, but they can educate patients on diabetes in general, how to check their blood sugars, how to use insulin, all of that. So it's a very large, dedicated, robust team of nurses that is really a big part of what we're doing. So some other team members, nobody's less important, but I wanted to just highlight the people that are doing the most work. The endocrinologist, often very important. But again, like all the other doctors, they're very medication centered, which for some patients is the right thing, but not necessarily for everybody. Um, and some patients that have more complicated forms of diabetes, like type 1, need that expertise of an endocrinologist. But for most people with type 2 diabetes, that level of expertise isn't necessarily needed. The dietitians are also really key members of our team. Again, I think we all know that diabetes is ultimately a diet, something that really can change based on what people are eating. We have a team of social workers, so when patients need help accessing care, like with rides, or have like food insecurity, need access to food banks, the social workers are really key for that. We have just 2 floors below our diabetes and medical practice, there's an on-site pharmacy, so patients can, go to the pharmacy right after they see Hannah or see their doctor. And if there are issues, we're on the same communication platform, so there's none of this calling back and forth from the pharmacy to the doctor or the provider. And then, a lot of the newer medicines like the Ozempics and Wegovys and Mounjaros, which are really helpful for diabetes. Not all patients have insurances that will pay for them, but we have people that can help patients navigate the drug manufacturer kind of free medication process. So, all right. And then, getting towards the end here. So, part of for us, what's really important about delivering good diabetes services is again, is monitoring how we are doing, not just trusting that we're doing the right thing, but actually seeing it. Um, so this is just kind of a snapshot of our diabetes dashboard. We have all the Health and Hospitals has just an amazing team of, they're called the Population Health Team, and they provide us with every single piece of data that we could ever want that shows us how we're doing with our diabetes patients. And something that may be of interest is that, recently in the last year or two, we've been getting a lot more breakdowns by patients' demographics. So we look at language in particular. This is a screenshot of like the racial breakdown. But this also really helps us inform, how are we are we serving everybody equally? What services, do we need to think about? Modifying or improving that really helps get everybody to the same level. And the other thing, I'm not sure if I really am allowed to share this, but I'm going to share it anyways. So this is, I'm sorry, the text is a little small, but so this is each of these sets of bars is a year, and that's the percentage of patients broken down by language. So on the left side, I'm going to hone in on Spanish, which is the center blue bar. So just a few years ago, our Spanish-speaking population was 26%, and that's gone up to 34% just in a few years, which is a very big change. Normally language does not change that much. And you can see the Russian, these are proportions. So actually the number of patients that speak Russian have been pretty consistent. They just haven't been adding at the same as much as our patients that speak Spanish. So, it's a real challenge for us, making sure that we have, I think I have this on here, when the demographics of our patients are changing, means we really need to think about, how are we meeting the patients where they're at, giving them what they need. So, the most basic layer that we do this is that we have really good interpretation services, including iPad video interpreters, which are much better and more personal feeling than using a phone, which is what we usually use or have been using. Printing materials in patients' native languages. So everything we have is in Russian and in Spanish, in addition to English. And, from my standpoint as a hiring manager, I am always looking towards, how do we hire people that, reflect the community, speak the language of the community, wherever possible, that's somewhere that we're looking. So I think that's all I have to talk about. So we're, happy to answer questions about anything, and we're very excited about what we have to offer the community for diabetes.
Should go.
Hi, can I just say that I,
Wait, okay, can you hold on? We have people here speaking in person first before we take questions from the Zoom.
I'll answer one and
I
then we'll
have
take
a
the Zoom
question
question.
and I really need to go. My name is Rochelle Manigault. I'm a patient of Dr. Nessa. I was in the office when Dr. Little came in and introduced the new pharmacist, and I said hello. I'm a Black lady. You came in there last week. Hi.
How are you?
I'm good. You walked into the office, you said, excuse me, you said hello, and introduced her to Dr. Nessa. I'm a
Yeah,
patient
so
that's been coming here.
that's familiar. I do a lot of walking around, but that's
Yeah.
it sounds
She's a geriatric doctor, and I've been going there for
yes.
many, many years. And I just want to say, you guys are wonderful. You do the best service. I really appreciate everything that y'all do, because I'm not going to be able to speak later, but I just wanted to say that really quickly.
I mean, we love hearing that, yeah, Dr. Nessa in particular, I know forms very strong bonds with her patients. So always good
Yes,
to hear the positive feedback. We like hearing the good, the bad, and the ugly. We like to hear the good to know that, we're on the right track. When we're not on the right track, we need to know. So thank you so much. It was
Okay.
great to
you're
see you
very
again.
welcome. The hospital's a wonderful place and everybody needs to appreciate it in this area. I'm sorry, Eddie. I just had to say that
No,
because
that's
I'm not
okay.
going to be able to stay.
Not a problem. Okay. All right.
Now,
Tatiana?
So yeah, I was just wondering if down.
I'm gonna look at somebody who has way more expertise than me in this. Yeah.
As
yeah, I'm sorry,
so
guys. I
for
just
my
wanted to speak to them for 2 minutes because they have these meetings, these community board meetings where they want to talk and ask 100 stupid
Okay.
questions. I just wanted to tell them, thank you very much for the services. It's my Coney Island Hospital. They have a new, yeah, they have a new clinical pharmacist.
Okay. Go ahead.
um
That was not purpose.
No.
I also have experience on the retail and the community end of pharmacy, and part of my training also included that as well. And unfortunately, I don't think the cash price of insulin has gone down, but I do know insurance plans, their formularies include everything. Best choice, not always, but they don't they don't leave patients like out to,
Out the dry.
yeah. um but I think that goes well beyond my pay grade. But it is
Yeah.
unfortunate, prices of medications, but there are other options where other suppliers, I think Walmart is the only one that I'm like very well familiar with, just because I'm from like the suburbs of Atlanta. I haven't seen a Walmart here, but
Down in Sydney.
there- um pharmacies have started formulating their own versions of insulin and have been selling it for a much, much affordable price. Yeah, so there are different options out there, but I do think as long as there is an insurance coverage of some sort, there are options that we can work with. And those are one of the things that our clinical services will cover. To make sure that you're getting, the safest medication regimen possible.
Is this a problem that you're facing in with you or your family, or is it more general? Yeah. Besides the donut hole problem, most of the plans have some brand that they cover or not. And this is actually another area the clinical pharmacists can be very helpful because you were just doing this earlier. They study the lists of all the medications that are specific to each insurance because sometimes changing the brand can help get a medication covered. Um, but almost all insurances have some insulin they cover. Again, Medicare does have the donut hole situation. And then again, our patients everybody with Medicaid has good access to insulin. And then our patients that have the NYC Cares plan. So if they're not able to get like regular insurance, we give them coverage through a hospital plan. They have access to insulin at a very reasonable cost. Like I believe it's a few dollars for a month.
All right. Next question. Minnie, you're next. Minnie, are you there?
So yeah, I'm here. So my
That's okay.
question has to do with preventative. I guess cardiology would be what diabetes is about. Is there any way that you could help the community have access to I guess, walking trails or exercise that would be part of the community that you could introduce? And could you also talk about the new food pyramid that just came out? And if you think that will
Well,
be helpful? in
Um,
decreasing the amount of people with diabetes? And do you ever try to get people off insulin and revert them to oral meds? Thank you.
yeah, these are amazing questions. So, I'm going to actually kick the question back to the community board in 1 second. But so is any patient that's coming for primary, our adult primary care services or any primary care services, we're always. I know I spent the whole hour talking about treatment, but we are always looking at prevention, and prevention is really the core of what we're doing in our primary care services. Is even if it's monitoring for diseases like diabetes, high cholesterol, high blood pressure, advising patients that, if they don't have those yet, making sure that we're, giving them access to dietitians and other people who can help them live a healthy life. So, if I'm hearing your message is, it's really important that we think about prevention, not just treatment, and I am 1000% with you on that. Um, the Sorry, you had a question about insulin, but I didn't write it down clearly enough. Oh, getting patients off insulin. Yeah. Oh, yeah. I mean, I love getting patients off insulin. And in fact, I was just meeting with another doctor today, saying how, or were we talking about that here? When the patients come out of the hospital, we're changing, they come in on taking insulin 4 times a day. And often one of the first things we do in primary care is at least cut that down to once a day or even cut it out completely. So it's very much a goal, that especially when patients are coming to us saying, like, the insulin is not the medicine for me. um we very much try and do that. The food pyramid, I mean, I'm not gonna I don't have a lot of expertise I don't have that level of expertise in in diets. I mean, some of the feedback that I've read from people that are more, they know more about the evidence and the science behind this. I think the emphasis on whole foods over processed foods. I think there's kind of universal agreement that's really great. I think the balance between vegetables and whole grains versus like meats and whole fat milk. So I think there's more controversy there. So I mean, for us, I will say what we do is that we very much focus on the kind of Mediterranean or DASH type diet, which is more heavy on vegetables, fruits, whole grains, legumes. And that diet emphasizes a little bit less on the meat side, which is pretty standard for diabetes care and primary care practices. Um, but yeah, I do acknowledge there's some controversy about the food pyramid in general. So as far as the walking trails, I'm not sure, but I'm all for walking trails. And what's that? The boardwalk, yeah. So
Yes,
yeah.
we need some to fix the boardwalk. That would be
Yeah,
great.
so if you need us to come to any community board meetings advocating for green spaces and walks and walking, we're there with you.
Great.
Great. Thank you very
Okay.
much.
You're
All
welcome.
right, next we have is Mark.
Yeah, thank you. I just had a question on the Dexcom or those things. A buddy of mine had to drive 2 hours every 10 days, 8 days to change his big sister's patch because she couldn't get anybody, whatever. She has the diabetes finally took her life. But I was just wondering, is that going to get any better changing the whatever the contact, the little patch thing, is that going to get any better than
Mm.
8 or 10 days? I don't know the exact numbers. I don't knock on whatever. I don't need the thing, and he doesn't, but his sister did.
Yeah, I mean,
Is
I'm
it?
really just sorry to hear about her, I mean, it sounds like he was, from what I mean, that's some real dedication to go to a family member's house every couple of weeks
Oh,
driving.
it's his parents are
So,
gone. It's his sisters.
yeah,
He
yeah.
went.
So, I mean, I don't know, Hannah, are
I can
you?
answer.
Yeah.
So I believe Libre Freestyle just came out with a longer duration. They originally had 14 days, but going up to 15. And there's studies going on about
You mean that meaning how many days that
Oh,
each
yeah.
device lasts before you have to change it out?
Yeah.
Yeah, that's
and
what I was referring to.
There's definitely ongoing studies for longer duration of methods to measure someone's blood sugar without having to continuously change it out. So I think there's things in the works to look out for, but nothing longer than a couple weeks for now.
Yeah. I mean, the technology is really
Thank you
great.
very much.
Yeah, we're to some extent at the mercy of what the companies do. I will say when they come out with newer, shinier models, you will see it on television. For better or for worse. It will be out there.
Next we have is Jeff Sano, our chair.
Good evening. It's a very, very important subject matter. I'm a diabetic type 2. Recently, I was on Traceba, and the insurance company stopped it, took it off the formulary, and now I'm on Lantus. Is there any problems with switching over from one insulin to the other insulin?
Thanks for the question. I'm gonna, this is demonstrating why this team-based approach and having the diabetes expert is so important. So I'll let Hannah take that.
No, I think I briefly mentioned this earlier when I was talking about the different, formularies and coverages. So it is a very real everyday problem that we come across, but there really, unless you have an innate allergy to a specific product, there's really not any difficulties switching between different types of insulin, depending on its formulations and duration. We might have to tweak with the dosages a little bit, but those are definitely things that we work with the patients to make sure that switch is safe.
Okay, thank you very much.
All right, is there any questions here? Any other questions? Oh,
Minnie's
we have
hand is
Minnie
up.
here. Minnie, if you want to ask a question again?
Just one more question. About insulin versus glucose for checking if someone is possibly becoming diabetic. Is it better to have a fasting insulin or a fasting glucose?
Yeah, so for somebody who doesn't, who doesn't already have diabetes, by far our best test is that A1C test that I was talking about before. So that's the blood test, which can be done at a lab, although we actually have finger stick machines in the clinic that will check the A1C, because that A1C is monitoring how is somebody's blood sugar doing over a pretty large period of time. Whereas if you just check your finger stick, your regular blood sugar with the machine at home, it could be it could be low on the reading when you check it, but you actually still could have diabetes because all the other million times during the day when you're not checking it, the blood sugar could be high. So the best way really is to see, a primary care doctor or provider. The general recommendation would be, at least every year, depending on your health status, it could be more frequently, but at least once a year to check in. When people talk about routine blood work, it's actually the A1C is actually the most important test for overall for most people in that routine blood work. So yeah, that's why and we're here for that, and we actually have really good access and availability in our adult primary care practices these days. So, all right,
Thank you.
welcome. That's it.
Yep.
All right.
Oh, well, cut.
Yes, actually, I'm pre-diabetic since maybe 5 or 6 years. And the doctors, they always tell me to avoid gluten. I don't know why,
Hmm.
but, do I have to definitely to be diabetic, or I can be saved?
Yeah, so that's a great question. I'm actually pre-diabetic as well. So I'm with you. Um, runs in my family. So pre-diabetes is a newer term. We invented this. We invented pre-diabetes, and the reason was exactly what you were talking about. So having pre-diabetes does not threaten your health in any way, moment to moment. But
Yeah.
it's a warning that you're at risk of developing diabetes. So that's why we put that out there. I'm actually very careful about using that term. I tend to just say people have high blood sugar, but not yet diabetes. Somewhat of a personal choice. But but yeah, so the pre-diabetes, means that there's a risk of diabetes, but it's absolutely not set in stone, or not a foregone conclusion. And that's exactly why we do this testing and use this diagnosis and talk with people about it. So I can't speak to your specific health situation, of course, but I can assure you that having pre-diabetes does not mean that you have a destiny for higher and higher blood sugars. And that's a big part. That's a big part of why we are here now talking to you all.
Yes, yes,
So-
because all the doctors, especially primary, they say, now you can control it, but after a while, they will control you.
Hmm. Um,
They scare us all the time.
yeah, yeah. I mean, I acknowledge that is a tactic that is sometimes used. And I think a lot of doctors were taught to do that over the years. The culture, and I'm sure obviously some doctors are still doing that. Our culture overall has really, it's hard to shift the culture of doctors, but that Titanic ship is slowly shifting away,
Yeah.
away from these scare tactics and more, I mean, again, I can't speak to you anything specific about you, but like for me personally, and I know Hannah does this too, is we don't we try not to focus on what you can't do, but what doing more of will help you. So like, eating more vegetables,
Yeah.
is helpful. Eating, more lean meats and fishes is helpful.
Okay,
So,
does that
yeah.
mean if I follow this, some diet, I will not be pre-diabetic?
So many people, I'll put it this way, many people who try really hard
Yeah.
to make diet changes, which are very, very hard to do.
Yes.
Like I have tried making them, it was very hard. Um, People that are really able to change what they're eating, usually the blood sugar, if not go down, doesn't go up or doesn't go up as much. And again, I can't, I'm trying to avoid being in doctor mode right now and just in lecture mode. But
Is it by genes or not?
there's a lot of genetics and a lot of genes in diabetes. Yeah, and that's actually one of the messages that I like to deliver to my patients is that, there's sometimes people say that there's this phrase out there that like somebody gave themselves diabetes, and that is almost no, and that's false 99% of the time. Diabetes is largely genetics and some combination of that and the food and the environment of all the junk that is surrounding us as we're sitting on top of the Texas
Yes,
restaurant.
yeah, actually, we have only one member, my uncle, but mom and dad, they are not diabetic.
Yeah,
So I don't know how come it jumped
Yeah.
from him to me.
yeah. Diabetes is almost entirely about bad luck. This is my standard. Oh, go ahead.
My twin brother is not diabetic.
Oh,
You're not diabetic either.
Maybe.
that's true. You're not either. So. Yeah. We'll have to find some study to enroll you and do one of those twin studies. Yeah. So, yeah.
Aerobic exercise.
Aerobic exercise. Yeah. Thank you all so much. You know how to find us if you need us. And thank you, Anna, for coming, working overtime. Overtime is definitely part of my job, but not part of hers. So really appreciate her coming. So
Thank
Yeah.
you.
you.
Yeah.
Informational
Yes.
session.
Yes.
Till next time.
Okay, have a good night.